a big change in the way we look at the diseases. It has started challenging the pathogenesis, which we thought was the right way to treat the disease and pathogenesis of the disease. So now we will have a gamut of speakers who will be speaking about the utility of wide field imaging in various situations, what it offers differently from compared to the standard fundus cameras. So it's my privilege to have Dr. Natarajan. We are missing him. Can I invite my co-chairperson, Dr. Shane Matthew and Ajay Arora, to be with us, with me here, please? I think, Prakash, can you call Ajay Arora? Darius? Yeah. So without much ado, I would request, in the absence of Dr. Natarajan, Dr. Shane Matthew to go ahead with his talk on multicolor imaging, multimodal imaging. Next talk. Prakash? Darius? Shilpi, your presentation should be ready on this screen.
Good morning to all. Sorry.
Yeah, go.
Yeah. So good morning to all. Thank you, Dr. Prashant, for inviting me for this talk. In the next 10 minutes, we will be talking about ultra-wide field multicolor imaging. Dream Big is what I've named it. You will come to know why I've named it Dream Big. So, multicolor imaging is different from conventional photography because conventional photography uses light to take images, whereas multicolor images uses 3 lasers, namely the blue, green, and red laser, to take individual images and merge it to form a composite image, and that's why we call it a multicolor image. This is a multicolor image of 3 different machines. By far I feel Mirante gives the best pseudo color, which almost resembles the normal color of the fundus. So this is a comparison on the left hand side of a multicolor, a color image from fundus photography when compared to a multicolor image of a patient with epiretinal membrane and significant cataract. You can see the clarity of the image and the sharpness and the contrast unparalleled in a multicolor image when compared to a normal color fundus photography. So why visualize ultra-wide field? Peripheral retina is the site for pathology in many retinal diseases like diabetic retinopathy, vein occlusions, uveitis, vasculitis, and rheumatous retinal detachment. As Dr. Prashant rightly mentioned, the conventional photography only gives us around 45-degree viewing angle of the fundus, whereas an ultra-wide field gives almost 200-degree. Mirante offers you almost 163-degree of fundus imaging in a single click. Ultra-wide field means any field which is beyond 100-degree, we call it ultra-wide field. And studies have also shown that ultra-wide field is superior to clinical examination detecting NVE in peripheral fundus of diabetic retinopathy. Protocol AA told us that predominant peripheral lesions were seen more clearly in ultra-wide field imaging, but it was not a predictor for 2-step worsening of diabetic retinopathy, which a wide field fluorescent angiography was. I would like to concise my talk into DREAM, that is 5 important points where a multicolor imaging scores over conventional imaging in retinal diseases. To document, to reveal subtle findings, to educate the patient as well as your residents, to analyze a situation where you are in the crossroad, where you don't know where to make a decision, and also monitor progression as well as response to treatment. How do you interpret a multicolor image? So this is the multicolor image of an epiretinal membrane. So here you have an epiretinal membrane, and here you have a schisis of the macula. So it is imperative to preoperatively plan to how to remove this epiretinal membrane atraumatically, because any further trauma to this area may have a visual deterioration. So the blue part of the image clearly shows the epiretinal membrane, and the schitic part is more clearly seen in the green reflectance image along with the blood vessels because it is intraretinal, and the red image shows details of the retinal pigment epithelium. So multicolor imaging helps us in preoperative planning in dissection of membranes. So this is a case of a color image, a wide field image of a multifocal CSR, you see areas of subretinal fibrin with a central dark area which corresponds to area of leak. A superimposed wide field angiogram clearly shows the areas of leaks were corresponding to those dark areas. So in patients where you're unable to do a fundus fluorescent angiogram, this may act as a surrogate marker to do laser to these areas. This patient had multifocal CSR with exudative retinal detachment. Multicolor wide field imaging may be a good documentation tool and an education tool many a times. This case of macula on retinal detachment, I was able to explain with the help of a wide field image to this patient why his vision is still good and you have a serious problem in his eye, and also able to teach my residents on how a horseshoe tail looks like and what are the signs of retinal detachment. It is of paramount importance in pediatric retinal diseases. ROP, as we know, the parents are very skeptical. You need to show them how the response is to treatment and what the disease entity is. And also in cases of FEVR, which is an ever smoldering disease, we need to find out areas of activity, subtle areas of activity, and start treating. For all this, wide field multicolor imaging is useful. Yet another area where scores over conventional imaging in subtle cases of vasculitis. As in this case, we might brand it as normal. I had a suspicion of vasculitis. The blue reflectance image clearly shows the areas of vasculitis in the periphery much more clearly. In patients where you have a myotic pupil, as this patient had a sudden loss of vision, I could hardly see the disc with indirect ophthalmoscopy. An ultra-wide field fundus imaging told me a whole lot of information. The patient had a massive RP rip with an exudative retinal detachment. The other eye had a similar finding as well. It is also helpful in monitoring optic disc edema. Again, the blue reflectance image shows a peripapillary whitening which slowly goes off as the edema subsides. So monitoring disc edema, also multicolor images do carry a role. Peripheral exudative hemorrhagic chorioretinopathy. This patient had a large peripheral hemorrhagic retinal pigment epithelial detachment which subsided on anti-VEGF therapy. It is cumbersome to note every subtle findings on every visit on the file. By taking ultra-wide field fundus images, we are able to see that, monitor the progress of the disease and also response to treatment. Patient had subretinal hemorrhage with collapse of the PED with anti-VEGF therapy, and you can see that the hemorrhage is slowly subsiding, and probably a decision can be made on cessation of therapy or to have a close follow-up on this patient. We know fundus fluorescent angiography might help in this situation, but you cannot keep doing fundus fluorescent angiography every time you have a doubt. So many times, wide field color fundus imaging comes to the rescue, but it cannot replace wide field fundus fluorescent angiography. This is another interesting case where we gave intravitreal injection for this diabetic macular edema patient 2 months back. 2 months later, he presents with sudden decrease in vision. You can see a massive choroidal detachment. You can see the ora serrata so clearly in this. Such a beautiful image though, not so good for the patient. Supranasally, I could see areas of subretinal fibrin with exudation. So patient had acute renal failure with fluid overload and exudation throughout the body. Had a puffy face and puffy leg along with similar effusion in the eye. All we had to do is closely observe this patient. As the symptoms of acute renal failure subsided, so did the choroidal detachment and the subretinal fluid. So it is extremely useful in monitoring cases and all to analyze cases when you are at the crossroads and don't know what to make a decision on. Peripheral retinal tumors, an excellent tool to monitor its progression and regresses following therapy. This secondary had a good resolution following chemotherapy. Vasculitis monitoring again is extremely important. This gentleman I followed up for almost 3 years. He was an oncologist by profession. Subtle areas of reactivation was picked up very well on serial wide field imaging, and I could prevent something which he had in the other eye because of using wide field multicolor. I mean, the other eye had a vascular occlusion by which he had lost vision. So I could prevent by closely following up with wide field imaging to prevent this vasculitis. As a matter of fact, I could reinitiate treatment. I could add a second immunosuppressive agent, but I definitely prevented this from happening. So close follow-up, diagnosing or picking up subtle changes are extremely useful in cases of vasculitis when you do a multi-color wide field imaging. Disadvantage of MCI is slightly long fixation period, artifacts like ghost images and lashes, color distortions, and a map effect of wide field imaging is always there, but the advantages do outscore the disadvantages as unsurpassed sharpness, contrast, and clarity to the images. A combined platform with OCT angio, and FFA and ICG helps us, and it becomes time efficient many a times, and the non-mydriatic property is a potential screening and documentation tool. Thank you very much for your patient list.
Great presentation, Shane. Especially when you pointed out the small pupil, we get so many situations which children walk into the clinic, they are very uncooperative with an indirect ophthalmoscopy, and you put them on and take a picture, and in these cases, even if you go to the IR image, don't even go for the color image, the IR image, there's no light coming out, and you're able to document the entire fundus. So it's extremely useful in these cases to do it.
So is the patient which has got a lot of photophobia, and post-operatively the eye is all congested and ballooned up, unable to see. Those instances also, as sir said, get beautiful images.
Yeah.
Thank you.
And before I move on to the next presenter, only it's not the disadvantage, I would just correct the word which Shen used for it. It is a limitation of the system at this point of time. It's a pseudocolors which we are using in this technology. So it's near normal color, that is the thing. And few of the disadvantage, rather I would label it as limitations. Yeah. So without much now, let's move on to the other aspect of this particular imaging system, which is the retro mode. So retro mode, I would request Dr. Shilpi Narnavre to familiarize you with this particular new entity.
Good morning, everyone. Thank you for this opportunity. So I'll be speaking on the retro mode. It is a new investigative tool which specifically images the RPE. We all know that because of the better understanding of the chorioretinal disorders, that RPE is not.
The image is not coming. Audio visual.
Excuse me, the image is out of.
Image. AV team. Are they having the problem? Till then we can have the next speaker. Shane? Okay, then I take this opportunity to invite Dr. Ajay Arora, a prolific vitreoretinal surgeon from Noida. He would be speaking on a topic, Widefield imaging in diabetics. तब तक आप सर को दे दो अगर टाइम लग रहा है वहाँ जाके चेक कर लेना पड़ेगा ये ले
Okay, so just to add on to what was just said about the problems related to the limitations, I find only one limitation with Mirante, and that is when you are taking a disc photograph and you want to, and especially for the glaucoma colleagues, because it is pseudo colors, you may not get the exact color. So when you compare the disc to disc photographs, then that's an issue. So I have kept my old fundus camera with me, but if you, there is a scale below on the Mirante where you can adjust the colors. And when you adjust those colors near to what you would get in a normal fundus photograph, we have to do it initially. And once you do it initially, then all subsequent photographs with the same color combination would come out same. So that is the only trick which is useful. So I'm talking about Widefield imaging of diabetic retinopathy, and I think this has already been mentioned to you as to what are the various, the evolution of retinal imaging from the first fundus camera, which came out in 1926, to where we are today. And what is the definition of ultra wide field imaging? So one line which was said by Nathan Chaudhary, he said, a single capture image which provides a view of the vortex bands in all four quadrants and beyond, thus meeting the wide field and ultra wide field definition, would offer enhanced efficiency in a real world clinical setting. So that should be the aim of, so there are numerous cameras available, but if I can get all the four vortex bands a little beyond, that is ultra wide field imaging. So this is what happens when you see with slit lamp, when with the indirect ophthalmoscopy, with a fundus camera, with a wide field imaging, with the ETDRS 7 standard charts, and with a wide field imaging. And if this was a study by Jocelyn AIOC et al., which showed that they were missing 10% of the time peripheral lesions, which would have changed their protocol for treating a particular case of diabetic retinopathy. Similarly, the peripheral non-perfusion areas, especially in cases of Behçet's disease, when we do a Behçet's disease, the pruning of the peripheral vessels, the problems which you get of peripheral areas of non-perfusion are all picked up on a wide field imaging. So this is what Mirante looks like. I will not go into the technical specs, that it has got a quadruple frequency 4 lasers so that it gives you a color depth imaging. And please, this is one thing which we must keep talking repeatedly. What is the angle which they talk about? What is the Optos angle? What is the Mirante angle? So let me come to it. If you draw a straight line, which is 180 degrees, they always say it gives you a 200 image. I have gone back to them and asked, how come you get 200 image which is beyond that 180 degrees? And nobody is able to answer that to me. So the Optos angle for Mirante is 160 degrees, which actually is in real degrees 110 degrees. So this is a normal image of on a small pupil. This is how a standard image looks like of Mirante, and this is what a wide field image looks like of Mirante. And here, as I said, uncooperative child, 7 years old, did not allow me to do an indirect ophthalmoscopy, and we were able to pick up. This is to document peripheral lesions. I'll go on to my talk on diabetic retinopathy very soon. So I'll present you 3-4 cases where actually changed the way we were treating our patients with diabetic. So this was a patient who had vitreous hemorrhage in his left eye, subsequently had a hemorrhage in the right eye, underwent vitrectomy with silicone oil injection. His visual acuity improved. He underwent a silicone oil removal, and then he had a recurrent vitreous hemorrhage. We allowed the hemorrhage to absorb, visual acuity improved. He had a fresh vitreous hemorrhage. We had taken him for vitreous lavage, did a fluid gas exchange, and at that stage, after the fluid gas exchange, I did this imaging. Now you can see here on this imaging, we had missed out a peripheral NVE. We had missed out large capillary non-perfusion areas. I went ahead and lasered that patient in the periphery. So if it was not for this, if I did not have a Mirante, what would I see? I'll just see this much of the fundus. But what I saw was this. So there's a difference between what I could see on a normal fundus camera and what I could see on Mirante. So this patient, we went ahead and lasered, and this is what the patient, we had lasered him adequately. And now I have followed this patient for last 18 months, and he's doing well. He's not had a recurrence after that. So it's 21 months, sorry. So then we treated the same patient in the right eye. He had similar pathology. You can see a large area of NB in the periphery. We went ahead and operated. We lasered these areas. This is just to again show you what we would have missed if we had done a normal standard imaging. And this is how it looks. This is another case who again came to us with a recurrent bleed. And normally looking at you will say, oh, you had so much laser, how can you bleed? But she did. There was a large area of capillary non-perfusion. She had a small NVE. We lasered that. This is what I would have seen on a standard photograph. This is what we saw on a Mirante. And that's how we went ahead and lasered. Same patient in the other eye, retina was more than adequately lasered. Why she's having a vitreous hemorrhage? Again, we saw peripheral NVE, which I would have definitely missed if I had done a normal fundus camera. So you see, this is what a normal fundus camera would reveal. This is what Mirante would reveal. So went ahead and lasered it, and this patient is again stable. Another patient who's, this is the area of capillary non-perfusion. This is the patient who was referred to us as a MACTEL, actually had vasculitis, large area of capillary non-perfusion. We treated the patient did well. Another patient who is 44 years, type 2 diabetic, again had been lasered before, went ahead intravitreal injections, good metabolic control. On April 22, did pars plana vitrectomy with extensive membrane surgery with oil injection, and this is how this is what the patient's angiography was. The areas of capillary non-perfusion. We went ahead and lasered those areas. Same patient in the other eye. He underwent surgery in this eye as well, and this is what the patient looked like both in right eye and left eye. So to conclude, the Widefield imaging gives us better images even when there is some amount of cataract, entire retina is covered. It helps us in young uncooperative pediatric patients, patients with small pupil. There is simultaneous imaging of the central and the peripheral retina. We can, as mentioned earlier, we can do an FA and simultaneous FA ICG. Fundus autofluorescence with both green and blue autofluorescence. And we can also take IR images where there's no flashlight. So therefore, the take-home messages, it has been documented that ultra-widefield imaging in diabetic retinopathy is non-inferior to the ETDRS standards, 7th standard charts. Ultra-widefield imaging of the periphery diagnoses more lesion than those detected by the ETDRS screening, and has been shown to change the diabetic severity scale in about 10 to 12% cases. The diabetic retinopathy cases, when imaged with the ultra-widefield, FA, the risk of development of PDR are very high, and then there is 118.2 disc diameter non-perfusion area. So if you detect such large areas of non-perfusion, you should go ahead and laser them. Lasering the periphery non-perfusion area may reduce the amount of anti-VEGF required in cases of DMA. Our experience of lasering the periphery non-perfusion area in cases of PDR has been very, very helpful. We have been able to, patients were having recurrent vitreous hemorrhage. Since I bought the machine, my incidence of recurrent vitreous hemorrhage in these sort of patients has certainly reduced. So this machine can allow us to see it, show it to the patient, and treat it adequately. Thank you for the opportunity. Thanks a lot.
Thank you, Dr. Ajay, for an excellent presentation on the usefulness of Widefield imaging in diabetic retinopathy. As you said, even I follow that. Post-operatively, I do keep doing an angiogram, which is many a times fruitful. And recently, the trend is towards doing an angiogram early in the course of diabetic retinopathy, especially a Widefield angiogram, to see for capillary non-perfusion areas. At least you can stratify the patients on how frequently you want to follow these patients. One with larger capillary non-perfusion, probably you follow them up very closely than the one with the lesser area of capillary non-perfusion. Thank you very much. Hereupon call Dr. Shilpi for her talk on retro mode, newer perspective. Not yet ready? Okay, sorry. Yes.
Dr. Darius, please.
Dr. Darius is a champion of Widefield OCT, and we'll hear from him what Widefield OCT is all about.
Yeah. AV team, can we have Dr. Shroff's presentation meanwhile?
So if anyone has any questions while we have this interruption of audiovisual, you're certainly most welcome to ask.
Can you explain a little further on the first thing? See, I always felt that even with all the so-called true colors or near-looking true colors, the images anterior to the anterior retina is mostly greenish, blackish.
Prashant Bavankole for this opportunity. And I think now that we've learned all about the Mirante system, we'll be viewing another system also which helps us with wide field imaging. And my talk is a wider perspective, and I thought I'd cover ultra wide field OCT and OCT angiography because that's something which is upcoming now. It is the new kid on the block, and we're finding it more and more useful to use it and pick up stuff in a non-invasive manner. I think Dr. Ajay Arora already told us that Dr. Ailo's group has defined the International Wide Field Imaging Study Group recommended wide field to be 60 to 100 degrees and ultra wide field to be about 110 to 120 degrees. And seeing is believing. So I think till you see it, you can't believe it, you can't treat it. And I love the acronym of Dr. Shane, that DREAM. So till we document it, educate our patients, and kind of reinforce it, we cannot treat the pathology and cannot convince our patients to get treated. So I think that's an amazing tip from today's talk from him. So SWEP source has really helped us to go wider and deeper. So basically there's no spectrometer, so there's no signal loss. And the electronic tuning is just getting better and better. You're getting faster A scans. So if you want so much depth and resolution, if it's not faster, the patient would be blinking and it would take too long. So this has really helped us with shorter acquisition times and more averaging and a better flow analysis. So how are we going deeper and wider? So now with a wide field OCT, we are doing 16 mm scans, which are up to 3 millimeters deep. So this is the advantage which we are kind of reaping a benefit of. And this slide shows the different scans over time. We always started OCTA with a 3 into 3 millimeter scan. But now we have got wider scans. We are routinely using 12 into 12. And the other scan, which is very useful for diabetic retinopathy, is a 15 into 9. So that gives a lot of information in a single scan. But the wow factor comes is the montage. So this is 5 scans. Each of them is 12 into 12. So 4 are incorporated, 4 peripheral scans, and you have a center one at the fovea. And together you get, I think, a little more than 100 degrees. So this is where you get 22 millimeters by 22, a very wide field view of the retina with this montage. So let's go into interesting situations. So this is, of course, this is a nephropathy patient, PDR with multiple NVEs, and patient was not allowed to undergo a fluoresceint angiogram, and see beautifully without a dye. We can pick up the raised NVE and we can treat this patient based on this wide field octa only. Regression of the NVE also, so we can monitor, we don't have to keep on doing invasive angiography. So I'd like you to, this is a study we published in the IGO. So this is the regression of the diabetic vascular. So you can even see the B scan. If you see this upper area, you see the raised vessels and the red dots are showing the flow. So before you can see how vascular it is, how many hundreds of red dots are within this neovascular tissue above. And post-laser, you can see the red dots have gone. So there's no flow. So the B scan is beautifully correlating with the actual NVE in the periphery in this patient. And you can see the beautiful images. So here we have compared the multicolor, the regular scan, octa, and this is the FFA. So you can see the leakage on the FFA, but you can't see the detail of the neovascularization. You can't see the fronts and all. But with the octa, you can beautifully see the details of the neovascularization and it regressing post-laser. Other cases, I think diabetic also, you can see beautifully, this is the FFA which shows it, but you can see the detail and beautiful kind of a front raised when you compare to the B scan. This is the octa image on one side, on the FFA on the other side. So it's a gorgeous image. It won the ASRS award. It was called the Flame of the Forest. So something interesting. This is the other cases where we use it. So this was a patient which underwent vitrectomy with gas bimanual membrane dissection. So pre and post-op, you can see the entire thing is flattened and the retina looks almost normal. Of course, the perfusion is not there. And a tight laser, as Dr. Ajay just told us, is the key for success, long-term success in these cases. So now I've just shown you beautiful pictures, but what about quantifying it? So there was a study from the US, from Washington University, which showed that the ultra-wide field protocol enhances automated classification of DR severity with octa. So this is what I think Dr. Shane also mentioned. So maybe these patients, we don't do anything actively, but you can see this purple color show is the CNP areas, which by image J, they've just kind of quantified. So patient who's like spectrum J rather than F, we would call them for more frequent follow-up. So I think Dr. Shane also mentioned that the follow-up becomes much more because these are more likely to go into PDR and require laser much sooner than somebody on the spectrum of G and H. So they've actually quantified it and shown on Okta how this is important. Other diseases, retinal vein occlusions, you can see how beautifully the capillary non-perfusion and the collateral forming is picked up. CRVO, I think one of my colleagues, Dr. Charu, is doing a study, which is even sent for AO. So there's a kind of a wedge of non-perfusion. So you can see this amyleric triangle, which keeps on increasing as the CRVO goes from ischemic, from a non-ischemic in the beginning to a ischemic CRVO. So this indicates closer follow-up is required. So just going back into the real world, this is a patient where we found this modality useful. It's a right eye STBRVO NVE. PRP done all the way back in 2007. Over 13-year follow-up, there were bleeds, but vision remains fine, and only observation was recommended. So you can see the image, you can see the raised tissue here, the sclerosed vessel and the laser. Here in the Okta, you can pick up this capillary non-perfusion and this raised area which was lasered. And the most important part of Okta, I think, is that you can do section by section. So it's like a cake you have on your wedding which has got multiple layers. You can just slice one aspect of it and know what's going on there, not what's going on in the choroid, not what's going on above. Unlike a fluorescent angiography, which you can see just one section, it's like a 2D, it's looking at the top of the cake. But here you can slice the cake and see what's going on in the intervening layers. So you can see the raised NV on the VR interface slab here. Second patient I wanted to just discuss was a patient who had leukemia, TLC was 1.8. Left eye had high pressures, ischemic CRVO, a very featureless retina you can see, but the Okta clinches the massive amount of capillary non-perfusion, and both the eyes you can pick up this beautifully using the Widefield Okta. What about PCV? I think PCV, every time you go for conferences, everybody says, plays pessimist. It says that Okta, there's variable flow. Somebody says the flow is too high. Somebody says it's too low to be picked up. There are a lot of segmentation artifacts. You have these huge PEDs, lots of blood. You can't see it. So we kind of try to find out whether we can use it to help up in our PCV cases. So the ICG shows the polyps better. See these two polyps. But the BVN is shown better on the Okta. So here you can see how beautifully the BVN, the branching vascular network, is seen on the Okta compared to the ICG angiography. Here again, you can see the yellow arrowheads are showing the polyps, and the BVN is seen with the turquoise color arrow. PHCR, peripheral exudative hemorrhagic chorioretinopathy, and one of my favorite diseases. So you can pick up beautiful peripheral polyps, both using ICG and Okta in this PC. And the B scan shows you the flow in this area. So this is a Widefield B scan which is picking it up. What about Widefield choroidal imaging? So this is another PHCR study where we did wide scans, and we found the choroid configuration was different. You normally have a bowl shaped, so you have a bowl, it's at the fovea, it's the thickest, and then it tapers off. But when I studied my patients with PHCR, I found a club-shaped configuration, like a claviate. So it's thicker in the periphery, and it becomes thinner as we come. So this was published in Retina, where we proposed PHCR to be added to the spectrum of pachychoroid disease. This is just a table and a graph from this same article. So just to conclude, Widefield OCT has a definite role in diseases involving mid-periphery and the periphery, critical for patients where invasive angiography is contraindicated and where you don't want to subject patient on follow-up to an invasive test. And response to therapy is amazing. You can do it frequently. Of course, the cost, the artifacts, and the challenges in capturing the image remain the bugbears of this technique. Thank you.
Thank you, Darius. And by the time Prashant is the next speaker, before he puts the slides on, both OCT and OCTA, do you think one day we'll give off all the angiography, the regular ICG and FFA?
I think maybe one day, but not yet, because you cannot see the leakage. That's the main problem. You can see the flow, but you can't really see leakage using this technique. So that's the contraindication. And certain other things I feel ICG is very useful is if you want to do, of course we don't have the dye now, but for pre-PDT I don't think we can depend only on OCT for that. So these are the conditions. But sir, you're right. I think as technology evolves, we will be moving forward.
I'm also working with some company in Greece and Germany to get the Visudyne to India. So I don't know.
Please let share.
No, I know, but somebody told me 3 lakhs. One of my patients was ready, but I don't know why we are not able to still import. Anyway, we hope to work on that. As a chairman ARC also, you have to do a homework to
Yeah,
get
Dr.
the
Prashant, I think
Visudyne to India.
The PDT dye, I think Dr. George was also telling me
So,
that through BRSI they're trying to.
Dadas, I have a question for you. When you showed these beautiful images, you're doing simultaneous FA and OCT in the same patient?
We did a pilot study with Dr. Shishir Narayan some years ago where we did do that. Now, since we are now confident about the Octa, we are not doing it simultaneously. But when we got the Octa new, we did a kind of same patient on both.
So when you said you found a lesion on the angiography or a particular lesion, to go to the same place on the Octa, a point-to-point, pixel-to-pixel correlation is difficult. You can approximately say it, but you may not accurately say
Yeah,
that.
because the machines are different. So you do have, I think if somebody has a Silverstone, they can do it exact because it's in the same machine.
Yeah.
But we are using separate systems. So the Heidelberg is capturing the FFA ICG and the Plex Elite is capturing the OCT. So you have to kind of do it in your mind or you have to do approximation. I'm sure you can make an algorithm for that, but otherwise you have to do it.
Prashant may have you are talking on FFA, ICG and OCT. While your talk, you can answer Ajay's point. Thank you, Darius.
Thank you.
So now we have our dynamic chairman ARC and a dynamic retina surgeon from Center of India.
Thank you, sir, for those kind words. So I would be taking you through this. We have already been introduced to Widefield angiography as well as Widefield OCT. This is a bouquet of cases, clinical cases, which I would be sharing with you to show how this system, why Widefield imaging is the need of the hour. So this all we know, and these are the types of cameras which we have already spoken about. So and this is what we already see and what in various types of ultra wide field and the amount of area in the retina which you can see. These are the options, the Optos, the Claris, the Mirante, Heidelberg, and these are various options which are available to us in the market which are offering these wide field imaging systems. The Mirante has a unique advantage because it offers FFA, ICG, combination autofluorescence OCT, and also wide field OCT as well in this single system. Now let us see some clinical advantages with the wide field OCT. In a standard wide field OCT, the length of the scan size is about 9 to 12 millimeter. This system, it is almost 16 millimeter. And this is especially important if you are studying simultaneously the associated extramacular pathology, some peripheral regions, and when we are doing this, the image resolution is well maintained. Now this is some of the examples from the textbook. I will just show you a few of the cases from our hospital. Now this is a mother of a pathologist who has a peripheral PCV. You can see on a color wide field photograph, a large peripheral mount, and on an OCT, you can see this is a blown out picture, and on a wide field OCT you can see the macula over here and also the scan which goes through the peripheral lesion, and you can see the fluid which is creeping into the foveal area, and this is the OCT which goes actually through the PCV lesion where you can actually study the image well. And this was the left eye wide field OCT where in a single go you see the optic nerve head, the fovea as well as the peripheral part. And in this particular patient, we treated the patient with brolucizumab as a single modality of treatment, and you can subsequently follow up this patient at 4 weeks, how the lesion is coming down or not, and without much having any invasive investigation, and you could see how it subsided with proper treatment. Now this is case number 2. Patient was diagnosed elsewhere as a case of epiretinal membrane and suggested surgery. At our center, when we repeated, you could see there was a membrane which was moving across, and this was the response. So this was just not simple ERM, this was more of a associated fibrous tissue along with the epiretinal membrane. So it helps you in properly deciding the type of a management which you are going to do in this case. Now another case, patient diagnosed elsewhere as a case of a epiretinal membrane with a lamellar macular hole. Yes, it is true. But now look at the picture. You have a wider perspective, now your diagnosis changes. You have there is a fibrous tissue which is pulling this and leading to traction. So this is tractional retinal detachment associated with schisis, and lamellar macular hole. So it changed the way we look at this particular disease. Another case, diagnosed elsewhere as normal, and they thought there is a blunting of the fovea and some epiretinal membrane. Widefield OCT, you can see this is a peripapillary schisis. So the treatment here totally changed. You had to treat him with steroids and all. Now coming to few of the, Dr. Ajay has already shown you the utility of the imaging system in the diabetic retinopathy. It helps you in detecting especially the peripheral neovascularization, and it helps you in doing a targeted laser therapy. This is specifically important when you are doing a resistant case of diabetic macular edema. You are injecting multiple anti-VEGFs, but there might be a pocket of peripheral dropout which needs a treatment and which can prevent, avoid the need of further treatment. Now this is a patient who came with these photographs. He had undergone laser and was diagnosed elsewhere to have a capillary dropout, and there was a bleed. And look at the difference, stark difference. You can see so much in this image. You can see that in this case there was just scatter laser mark. This area was not covered adequately. This is the hemorrhage. In the left eye you can actually see the hemorrhages lying over here. And a Widefield angiogram could show you that the dropout area was not necessarily only restricted to the posterior to the equator. The standard teaching is that proliferative diabetic retinopathy is a posterior pole disease. So that means we used to do pan-retinal photocoagulation only up to the equator. While this challenges our basic understanding of this disease, that yes, the dropouts can extend even anterior to the equator, and so is the need of extending your pan-retinal photocoagulation right from the arcade up to the ora serrata, at least in cases where there is recurrent bleed or in a case of a recurrent diabetic macular edema. Now similarly, in a case of a retinal vein occlusion, this is the picture that the patient was carrying, and he had bleed and all those things. And look at the how much extra information you are getting. Actually, you know the area where you need to do a sectorial laser, which has to be as extensive as that. And on a Widefield, you could see further. So this is what we learned from these few cases. Now this is another case who was 67 years old male who was advised to have diabetic macular edema. He was a diabetic patient. He diagnosed elsewhere as diabetic macular edema and was advised anti-VEGFs. Well, when we did a Widefield OCT, our way of looking at the disease was that I could see the sciatic cavities, even both the eyes, extending quite into the periphery. So it was not just simple diabetic macular edema, but this was a case of a macular edema along with a retinoschisis in a case of a diabetics. And when we look at the image, we really did not know, we did not see anything specifically. So we did an angiogram for this particular patient, especially in the right eye where the edema was there. We could see that there was an associated peripheral telangiectasia. So this associated peripheral vascular telangiectasia in a case of a retinoschisis was the reason for superadded macular edema in this particular case, and so we treated this particular patient with a laser in this peripheral area, and once we lasered it, the need of anti-VEGF could be avoided. Now this is a patient who was diagnosed elsewhere as a case of a partial retinal detachment, but when we saw on a field photograph, we thought we are seeing some fibrous tissue. We bothered to look into the other eye, which is very important. And here also you can see that there is a fibrous tissue here. So it was not just treating the eye which is symptomatic, but it is equally important. This picture teaches you why you should look into the other eye which is asymptomatic. And this is a case where we could do a Widefield angiogram, which is not possible to pick up this disease. So importantly, we treated the better asymptomatic eye with a laser and averted a disaster which had already happened in the left eye. Of course, we operated the left eye, and this is the post-op photograph of the same patient. Now this is 52 years old, diagnosed elsewhere as epiretinal membrane and was advised vitreous surgery. Now look at it. We did a Widefield OCT, and when we did a photograph, you could see that the blood vessels were drawn down. So they were being dragged. And so it was not just a case, it was again a case of FEVR with a vitreomacular traction, which meant you just did not need vitrectomy with a membrane peeling, but you also needed to dissect the peripheral tissue to take care of this disease. 48 years old male, systemic disease as quoted over there. diagnosed elsewhere as a case of Roth's disease. And when we did a Widefield angiogram, you could see the terrific shutdown in both the eyes. He was investigated and he was found to have a bilateral carotid disease, and this is how we could prevent a so-called morbid condition in this particular patient. Similarly, this is diagnosed elsewhere as ERM with full thickness macular hole, and when we did, this is the Widefield photograph, Widefield angiogram, and this is almost a half zone type of image which you can see in this particular case. This is 26 years female who was Montaux positive and had a healed choroiditis, but she complained of progressive loss of vision, which we could not explain on the basis of healed choroiditis patches. So we decided to do a fluorescein angiography, and we could pick up a peripheral dropout, and we had to treat him with laser along with steroids. Other case, 48 years old male, sudden loss of vision in a healed choroiditis. Through this hemorrhage, we could do an angiogram and we could see that there was a peripheral dropout which needed treatment. So as I can go on with this is the last case which I will share with you, an interesting case. Female diagnosed elsewhere as a Eales disease with combined and was advised vitrectomy for combined retinal detachment. This is fine, everyone accepts it. But when you look into the better eye, which is asymptomatic, you can see on a Widefield photograph there is something called pruning of the blood vessels. When we did an angiogram for this particular patient and further systemically evaluated, this young girl had a Takayasu's disease, so we treated the better eye before we touched the eye which was symptomatic. So this is how it changed my way of looking. Another last case, this is a girl, 19 years old girl who had a thumbsical right eye following some vascular tumor. Look at the family history. We looked into the better eye, asymptomatic. Even to the experience of 20 years as a clinical retina specialist, I thought it is normal. But that history, family history, and that history did not leave me comfortable. So I decided to do a Widefield angiogram for this particular patient, and look at this. Multiple angiomas and a case of a von Hippel-Lindau. So we treated this patient with LIO with triple freeze cryo, and you can actually document the whole thing. Look at this. Now, in a case whenever you have a VHL, you always need to understand there can be a family history. Look at a symptomatic father. Yes, on an angiogram you could pick up a lesions which were lying. Again, a brother who was asymptomatic. Again, look at his angiogram, Widefield angiogram. We could pick up an angioma in both the eyes. We did naturally, in this case, treat both the things. But look at it, how Widefield angiography can be helped in such cases. 1 year later, the guy has some new lesions and some old lesions which are not treated. And so a repeat fluorescein Widefield angiogram was done. Of course, we did a genetic study and we could pick up the gene which was involved. But this is what we should learn. Widefield angiography in such cases can help you out. So my list can go on like this with multiple cases, the importance and the utility of Widefield angiography and OCT. But here I end my talk, and thank you once more for this opportunity. And thank you, KLB Instruments, for having this wonderful instrument with us in our country, and for this opportunity as well. Thank you.
Thank you, Prashant. I know you have to go to another hall. In the meantime, Shilpi, you can start your thing. So I think wonderful thing you highlighted, like what we missed not seeing the periphery. So that's why in the screening, even though we do, Dr. Rajay is our chairman for AOS diabetic retinopathy screening, where we only take disc macula, but those patients don't even go for a retina photograph. But when we, as a retina specialist, I think we have to concentrate on both center and the periphery. Thank you.
You know, a lot of work which Prashant does, Shilpi is the backbone behind it.
Once again, so I will be speaking on the retro mode, which is a new instrument or new diagnostic tool in the basket. So it specifically images the RPE. So we all know that RP is outer retinal blood barrier. But we also know that it is not just only the outer blood-retinal barrier, it also is a hot seat for melanosomes, for visual cycle, for immune privileged cases, and also a hot seat for various diseases, that is chorioretinal diseases. And this concept is borrowed from retroillumination of the slit lamp, which specifically sees the cases behind, in front of the iris. So it uses 4 lasers. It has 8 apertures, that is 5 confocal and 3 apertures. The specificity is that the apertures are laterally deviated. So it always absorbs the light only in the one direction. So these are the various advantages, that it is non-invasive, it uses infrared laser and can also be used in non-mydriatic eyes. So let's first see how the normal retina looks on retro mode. So this is the color photo and the OCT and the corresponding FAF photo of the normal retina. And on the retro mode, we only see the ribbon-like choroidal blood vessels, which is normally seen on the retro mode in a normal retina. So now coming to the various diseases. So this is a case of retinitis pigmentosa, the central involving. And on the FAF, you see the hyper and the hypoautofluorescence, while on the retro mode, you could see some diseased RP alongside, which is involving beyond the central area. Now another case of paravenous pigmentary disease. So in this case, on the FAF, you could only see some hypo and hyperautofluorescence, while on the retro mode, you could see that the whole of the RP is diseased with the prominence of the choroidal blood vessels, the large choroidal blood vessels inferiorly. This is a case of cone dystrophy. The center is involved. On the FAF, yes, the classical pattern. And in this case, retro mode was not much contributory, as it only shows the diseased retina in the central part. So now let's see the RP dystrophy cases, whether retro mode helps us in these cases or not. So a case of Stargardt's disease, on the FAF, yes, you could see the various hyperautofluorescent lesions throughout the retina, and on the retro mode, we could see that this disease pattern is not limited only to the posterior pole, but is extended much beyond. The case of pattern dystrophy, in which the FAF is diagnostic, but we could see that the whole of the RP is diseased beyond the central area and is totally swollen out. A case of Best disease, in which the central part is involved, FAF shows the classical hyper and hypoautofluorescence. In this case, the retro mode was not much contributory, as it only showed the block fluorescence in the central area. Now coming to the other macular degenerations like dry AMD, this is a case of moderate dry AMD in which FAF is not much contributory, but when we looked at the retro mode, we could see there are swollen vesicles all over the retinas, prominently, which was corresponding to the color photo drusense. Okay. Another case, you could see these are the blisters which are seen all over the posterior pole and the prominence of the large choroidal vessels inferiorly. Now a case of soft drusen. On the color photo, yes, you can see these are the soft drusens. On the FAF, it is not much contributory, while on the retro mode, you could see the drusen is not only here, which are vesicles, swollen vesicles, but even in the periphery, you can see, that is beyond peripapillary area, you can see the blisters. Case of cuticular drusen. Similarly, FAF is not contributory, but yes, on the retro mode, the whole of the fundus is full of vesicles. A case of drusen plus pigments. It is a case of a 70-year-old male where you see that there is some pigments over the macular area and you suspect that it is because of the AMD. But when we did the retro mode, the whole of the RP is unhealthy. And when we looked at the other eye, the RP look unhealthy, means something is going on in the RP and it can be a cause of AMD. A case of dominant drusen. In this color photo, you see that drusens are only parafoveally, temporal to the fovea. FAF, yes, only the lesion is seen temporal to the fovea, but on the retro mode, besides this, the whole of the posterior pole is full of the drusens. A case of PCV, when we did, there was a fluid on the color photo and the OCT. Octa picked up the lesion. FAF showed some hypoautofluorescent, and in this case, the retro mode was not much contributory. We could see few lesions in the periphery, but it was not much contributory in this case. When we looked at the infective pathologies in the toxo scar, the central involving, so it only showed the blocked fluorescence because of the RP unhealthiness. A case of choroiditis, yes, the peripapillary choroiditis, we see the FAF showed some hypoautofluorescence, and on the retro mode, you could see only the prominence of the choroidal vessels in the diseased area. This is a case of retinoschisis in which this is a color photo and OCT, and on the FAF it was not contributory, and even on the retro mode you couldn't find anything else. So a case of CSCR, there is the fluid of the macula, and we could only see few deposits in the periphery with the fluid blocking the underlying choroidal pattern. This modality is most important in diagnosing the difference between the VKH and the CSR. If we see a case of a VKH, we could see that the whole of the RP is bumpy and unhealthy, it's swollen kind of appearance which we could see. So if you are not sure whether this is a case of a CSR or a VKH, this modality can help you in differentiating between while doing the retro mode. Another case of posterior VKH, in which you can see on the retro mode, the RP is totally unhealthy, while in case of the CSR, RP is usually healthy. So this is the case of idiopathic choroidal folds. On the color photo, you could see the band-like prominences over the posterior, over the macular area. But in the retro mode, you could see the ribbon bands which are more prominent and more clearly observed. So with this, I end with the case series, and this is the limitation that it is only available in the F10 microscope. At present stage, it cannot replace the other modalities. We cannot detect the disease activity of CNVM on retro mode. Mechanism behind it cannot be described fully. We cannot differentiate between the flat PD and the RP irregularities, and it cannot localize the exact depth of the lesion within the retinal layers. Thank you so much.
Thank you, Dr. Shilpi. For this, just for the sake of the audience over here, we have different ways of looking at retinal pigment epithelium. The cross section, when we get to do it with the OCTB scans, where we can understand the anatomical part of it. Then the other way of looking at retinal pigment epithelium layer is to do a fundus autofluorescence. Fundus autofluorescence has a lot of limitation because you could see, if you see the comparative pictures between the retro illumination versus, you get a very limited information on which we have to make our diagnosis, base our treatment. In a retro illumination, it adds further to this. Actually, each cell of retinal pigment epithelium which is diseased looks like a blister, and you can actually substantiate it. And in many of the diseases where the predominant involvement is of the retinal pigment epithelial layer or a secondary involvement of RP because of a choroidal disease, those RP disease cells stand out much more better. You can quantify them. You can in fact see the areas of involvement in a better way. So it is adding a new way of looking at retinal pigment epithelium diseases, rather I should say. It's a new modality of treatment. We really do not know the information which this modality is giving us. We are trying to analyze and understand how it can be put to clinical utility with the confidence that this is what it means. That's it. Thank you.
Yeah, thank you.
So now we welcome, the youngest ophthalmologist of AIOS, our ex-president, and sir is active in so many fronts that if I start talking about it, it'll probably take next 10 minutes. Welcome, sir.
Thank you.
We're talking on FAICG in AM.
Yeah, thank you, Ajay. And so we all know that fluorescent angiography was introduced in ophthalmology by Novotny and Alves in the 60s of the last century. I'm glad that Dr. Patnaik introduced that in Delhi in the early 60s after his fellowship from Switzerland. And initially they used this technique in diabetic and hypertensive patients, and after the technique was used in ARMD. And FA is the most important ancillary test for classifying the disease in its different subtypes. And we know the dry AMD with a hard drusen, soft drusen, focal hyperpigmentation, geographic atrophy of RPE, and the extent of the lesion. So here you see the drusen and RPE abnormalities. Several types of drusen can be identified. Hard drusen are small, less than 63 micron, round, well-defined yellowish deposits that correspond to accumulation of hyaline material in the inner and outer collagenous zones of Brooks membrane. On FA, they appear hyperfluorescent as transmission defects due to overlying RPE thinning. And RPE abnormality, just now both Shilpi and Prashant spoke. Focal hyperpigmentation is a risk factor for the development of choroidal neovascularization, and angiography appears as a blocked fluorescence, and histopathologically it is characterized by focal RPE hypertrophy and pigment migration into subretinal space, published by SPIC. And atrophic AMD, atrophy can occur in sharply defined areas of severe atrophy known as geographic atrophy, or in less well-defined, more granular regions of less severe atrophy known as non-geographical atrophy. And the angiographic appearance depends on the remaining pigment with RPE and choriocapillaries. And in the GA, typically shows late, well-defined hyperfluorescence from staining of the exposed deep choroid and sclera. In these cases, visual acuity depends on the foveal involvement. And here we have the wet ARMD, the classic, occult, and the RAP with the different types. And in the classic, you have characterized by well-demarcated hyperfluorescence in early phase of fluorescent angiography and late leakage that obscure the boundaries of the lesion. And angiographic classic CNV appears as a lacy or bicycle wheel pattern. And depending on its location, it can be classified as extrafoveal, more than 200 microns from the foveal center, and juxtafoveal 1 to 199 microns from the foveal center, or subfoveal involving the foveal center. And classic with the loculated fluid, the dye pooling is well demarcated in a confined space of a localized sensory retinal detachment or with intraretinal cystic spaces. And depending on their sizes, classic CNVM can be classified as small, medium, and large. And occult CNV has been categorized as fibrovascular PED or late leakage of undetermined source. And late leakage of undetermined source type 2 lacks a discernible, well-demarcated area of leakage in the early angiographic frames. Speckled hyperfluorescence with no visible source becomes apparent 2 to 5 minutes after the dye injection. And RAP has been described and classified by Enuzzi et al. In RAP, the vasogenic process originates in the retina and begins as intraretinal neovascularization, stage 1, which progresses to subretinal NV, stage 2, and finally to CNV, stage 3. In some cases, it's possible to find a retinal anastomosis. Angiographically, early lesions show a focal area of intraretinal hyperfluorescence with indistinct borders corresponding to the intraretinal neovascularization and surrounding intraretinal edema. In stage 2, it's very characteristic to find a serious PED with occult CNV associated to overlying cystoid macular edema. Although RPE tests can occur spontaneously, it is not uncommon for them to occur after treatment with thermal laser, PDT, or anti-angiogenic therapy. So this is where the complication, when patient asks, is there any complication, we have to tell them upfront. And RPE tears are commonly related to PEDs, although they have been described in classic lesions too. And the detached monolayer of RPE scrolls toward the CNV, leaving a denuded area of choroid exposed. On fluorescent angiography, the denuded area becomes hyperfluorescent and the scroll RPE is dark and blocks the underlying fluorescence. Hemorrhagic AMD, FA is not very useful in hemorrhagic forms of macular degeneration since blood blocks the underlying fluorescence. A disciform scar is the end stage of a manifestation of untreated CNV, namely formed by fibroblasts and inflammatory cells. Angiographically, it typically shows late staining. And ICG angiography in ARMD is we know what it is, and then the importance of ICGA is identify the subtype of CNVM in AMD, the type 1, type 2, type 3, to differentiate ARMD lesions from simulating lesions. That's where the expert's opinion, apart from all this imaging. Hotspots visible in an area of exudation, PED with small CNV at the margin of the lesion. ICGA, only the vascular component of PED appears hyperfluorescent. and exudative AMD, plaque with poorly defined margins in the late phase, as you see in the picture A, and CNV has been reclassified as focal spots or hot spots, plaques or mixed forms, a combination of the first two forms. And you can, in the lower bottom picture, you can see two hot spots, the lower spot being more active. And CNV may be located at the margin of the lesion, marginal spot, above the lesion, overlying spot, or at a distance from the lesion, remote spot. And ICG angiography is very useful in these cases for establishing the presence or absence of associated neovascularization, since choroidal neovascular membrane may be masked by the hyperfluence of PED when the fluorescein is used. And if FA proves inconclusive, ICG angiography may confirm the absence of neovascularization. And ICGA is very useful for diagnosing and classifying CNV associated to serous PED, distinguish between the serous and the vascular component. And classic CNV, which is better visualized with the FA in the early phases, since it masks the late phases by the hyperfluence of the entire lesion. And occult CNVM, where ICGA can show hot spots on the black image of the PED associated to RIP, the yellow arrows are the polyps with the red arrows. And this is a retinal angiomatous proliferation, and the retina image sources taken from our own Mirante, from AIOC2024, and also from the AND2book.org and retina image bank from the ASRS. And so as a treasurer of the International Council of Ophthalmology, welcome you all to World Ophthalmology Congress on 16 to 19 in August 2024, Vancouver. And I am also the president of Asia Pacific Ophthalmic Trauma Society, become a member of the most active society of the ophthalmic trauma, and where imaging is very important for pre-op, intra-op, and post-op. Thank you very much.
Thank you, sir, for those very important points that you have shown us. So I would now ask Darius, can you come here? If there are any, can you join us here, sir? If there's any question answers, if people want to ask anything on the Widefield imaging. Come, you have any questions?
His talk is the next one.
Oh, sorry. I thought, I'm so sorry, I'm so sorry. So there's the last talk by V. Prakash on interesting cases. I'm very sorry, I thought it was.
I thought it's over. You also. I told you, no, we use the time.
Yeah.
Yeah, thank you, Dr. Prashant and NIDEC, for this opportunity. And I think it was even okay, even if I didn't speak, because most of my interesting cases has already been covered by previous speakers. Because my experience with NIDEC is only last 3 to 4 months. And so many cases I don't have even proper longitudinal follow-ups of these cases. And I don't have an OCT of Mirante, so I use most of the pictures used in my OCT. No, this is not the presentation. Dr. Prakash.
I think it's my duty to introduce Dr. Prakash. He's a prolific VR surgeon from the northern part of Kerala, and he has a wide experience in managing these type of diseases. Over to you, Prakash.
Thank you, Shane. So with that, my job is actually, So I start with the first case. This was a 17-year-old boy who is on danazol for aplastic anemia. He came with diminution of vision in his left eye. This is his right eye, which is perfectly normal. And if you look at the left eye, you can see that there is some kind of granular material between the disc and macula with hemorrhages along the edge of the lesion. And the Widefield photo, actually there are some artifacts in this photo, but actually there is no other lesion in the periphery, only that posterior pole deletion between the disc and macula is seen. And an FAF picture clearly shows granular hyperfluorescence between disc and macula, and blocked fluorescence due to the hemorrhage at the corresponding to the hemorrhages on the retina. And if you look at the OCT, you can see that there is an active portion of the lesion, a retinitis. It's a retinitis lesion, and the active portion is a full thickness retinitis, which is casting a shadow behind, and there is the classically described as a cavernous type of outer layer defect that is very characteristic of CMV retinitis. And here the healing lesions show early atrophic changes. There is a granularity of the inner retina, and there is a drill change, disorganization of inner retinal layers setting in, and the retina is going down, subsiding, with an ILM getting detached from it. The ILM is fairly reasonably preserved, and you can see the vitreous
exudates overlying the underneath the ILM as well as in the vitreous cavity. So these features are what is typically described for CMV retinitis. Basically here it is not the fundus photo but the OCT which clinches the diagnosis of CMV retinitis, and this patient was treated with intravitreal ganciclovir with good response and healing of the lesion. And the healing pattern also is very interesting in these cases. You can see that there is a full thickness atrophy of the retina which was affected by the CMV retinitis, and the ILM is separated, the rest of the retina appears subsided down. So this is a second case where a 38-year-old male came with floaters in his left eye. Both eye he has 6/6 and 6 vision. The fundus photo of the right eye shows the periphery, you can see almost till aura. There are peripheral sclerosed vessels and corresponding angiography shows extensive CNP areas in the periphery. There are multiple neovascularization, neovascular fonts, shunt vessels in the periphery, and you can see the whole extent of CNP areas very clearly. Similarly, in the right eye, which had a mild vitreous hemorrhage which was causing the floaters, here also you can see the angiography clearly shows the capillary non-perfusion areas as well as the neovascularization. So we could do a well-guided photocoagulation to the periphery, the peripheral CNP areas for this patient, so that the new vessels regressed well post-treatment. So case 3 was an interesting case, 48-year-old female who came to us some kind of visual disturbance in her left eye, but vision is 6/6 and 6, and the fundus photo, the wide-angle photo shows some kind of elevation along in a circumferential pattern along the equatorial area. You can see that lesion there very clearly. This is other eye which is perfectly normal. Here an ICG FFA was done, but this was done in a Heidelberg machine. Here you can see there is some kind of hyperfluorescence in the early phase both on ICG as well as FFA, and late there is increase in hyperfluorescence, but on ICG you can see corresponding to those placoid lesions, you can see blocked fluorescence on the ICG, which tells you that the lesions are at a deeper level, sub-RPE probably, and OCT clearly tells us the lesion where exactly it is located. It's under the RPE close to the disc at the posterior pole, and if you look at those, take scans along the equatorial area, you can see the bumpy RPE. The RPE is bumpy and there is some material underneath the RPE, and between the RPE and sensory retina also you can see some exudative material. So these findings, especially this OCT as well as with this kind of picture, it's a very clear-cut case of primary intraocular lymphoma, and this patient underwent a vitreous biopsy as well as I took subretinal biopsy also, did a retinotomy along that area above the arcade and took the subretinal material, and endolaser and C3F8 was injected, and at the same time we had given injection rituximab by this patient. This is a post-op photograph where you can see that there is a large RP drip. Most of the lesions actually resolved very well, but the large spontaneous RP rip developed inferiorly, that is not at the area where the retinotomy was made, but exactly inferiorly in opposite direction. And the biopsy turned out to be positive for primary vitreoretinal lymphoma. This patient was managed with multiple injections of rituximab and methotrexate. This is the OCT which shows the response of the lesion immediately post-injection. And here at the superior area where we initially saw the multiple RP bumpy areas, you can see that the RP has become flattened now. And you can see my area of retinotomy also which was made during the surgery for the subretinal biopsy. But unfortunately, after the third injection, patient did actually very well, but after the third injection, patient came with sudden drop of vision. Now I can see a vascular occlusion. There is cattle trucking of vessels inside in the retina. I don't know whether it was due to infiltration. We could see some cells also in the vessels. Whether it was infiltration of lymphoma cells into the vessel or it was due to the injection, I couldn't tell, but the vision dropped for the patient. This patient was started on systemic steroids, and vision gradually improved to around 2/60 in later period. So this patient is currently on treatment. So systemic rituximab also has been started. This is the fourth case, which is a 60-year-old man who came with the gradual diminution of vision in right eye, diagnosed as CRAO elsewhere. When we did an angiography, you can see that there is extensive, even in the late phases, there is no filling of vessels, only there is some vessels around the disc, but rest of it completely occluded vessels. There is a total non-perfusion of the retina, and this patient on MR angiography showed a complete occlusion of the carotid system. This other eye which shows mild NPDR only. The case number 5, where a 47-year-old female who had history of breast cancer was on treatment, came with some vague visual complaints in her right eye, and you can see on the fundus photograph there is an elevated lesion along the superior arcade just above the disc, and on an angiography, you can see there's granular hyperfluorescence in the early phase, which is leaking in late phases. And that's a wide angle angiography, which shows a lesion clearly. There are no other, except for a small hyperfluorescent spot here, there are no other lesions seen. And ICG shows the intrinsic vascularity of this lesion. And when a PET scan was done, there was multiple spinal mets also for this lady, and this lady was referred for palliative care. So that's the OCT of the same lesion, of the metastatic lesion in the choroid. Deep in the choroid, you can see the elevation and total full thickness choroidal involvement. This was another case. It's already been, we have seen many of these cases actually. This is a 69-year-old lady who was referred as melanoma because of a brownish lesion in the periphery. And that's a peripheral. When you tilt the eye a bit, you can see almost till the aura, and you can see a large pigmented lesion here with a lot of exudate surrounding it. This is nothing but a sub-RP bleed in the periphery. And the fluorescein angiography, wide angle angiography shows multiple RP defects in the periphery, and in the late phases you can clearly see the PED with a little pooling inside. And the ICG, wide angle ICG clearly shows the peripheral polyp. So this is a case of peripheral exudative hemorrhagic chorioretinopathy, which was treated with the peripheral laser to the lesions with good resolution of all the lesions. That's a OCT, peripheral OCT through that particular lesion. And this was a 25-year-old male who was referred for to rule out ATT toxicity because he was giving some visual symptoms. Actually, he didn't have ATT toxicity. He had 6/6 and 6 vision, both eye. But what we saw was on the fundus photograph, you can see there was some small yellow dots, yellow lesion, deep lesions. It is not. Yeah, just here you can see the small yellow lesions, which was not very well defined on the wide-angle photo. But we did an angiography, fluorescein angiography, and ICG. Angiography didn't pick up the lesions well, but on ICG you can see there is a full thickness, multiple lesions in the deep choroidal level, which are persisting even in the late phases, which tells you that it is almost full thickness. So these are the choroidal tubercles which are seen in miliary TB. This was seen in his other eye also. These lesions were clearly seen on the wide-angle ICG for him in the other eye also. So he underwent ATT with a good resolution of all these lesions. So this is case number 8, where a 28-year-old female who came with a transient diminution of vision in her right eye. There's a large, there was disc was swollen, and there's a large area of subretinal hemorrhage below inferior to the disc. And the fluorescein angiography clearly shows there is a CNVM, peripapillary CNVM, and the blocked fluorescence due to the hemorrhage. So this was a case of peripapillary CNVM. This patient actually on evaluation turned out to have sarcoidosis. She has a peripapillary granuloma with secondary CNVM. So that's all about, I think the NIDEC Widefield imaging is a very useful technique for especially this kind of peripheral exudative choroidal chorioretinopathy as well as retinal vasculitis, to get a very good picture of the periphery, which otherwise you wouldn't have treated in many of these cases. Thank you.
Thank you, Prakash, for showing those beautiful cases. You have any doubts, any queries? Be free to answer. Due to lack of time, I think we'll wind up if there are no more queries.